All right. So far we've been talking about bleeding in the epidural space, which is a potential space here between the skull and the periosteal dura. And typically it occurs, it's secondary due to a rupture of a meningeal artery. Now we're going to switch gears a bit and talk about the subdural space, which is created by a subdural hematoma. So again, it's not normally there, and the subdural space is between the dura and the arachnoid. And here you can see those little dark bars at the center of my cursor there. Those represent the tight junctions that create the barrier properties of this portion of the arachnoid. So those tight junctions in the arachnoid barrier layer prevent venous blood or sort of lock venous blood in this potential compartment. And it's typically a venous tear that causes bleeding into the subdural space. So if you remember that there are bridging veins that travel from the subarachnoid space into the sagittal sinus. That is how, so we know that cerebral arteries and veins typically occupy the subarachnoid space. But of course, those veins have to bridge the meningeal dura in order to access the sinuses, in this case, the superior sagittal sinus. So it's typically a tear of that vein on its journey superficially, and that causes leakage of venous blood and creating a potential space then between the dura on top and the arachnoid beneath. And it sort of bursts in and invades when that vein tears. Now, you can see it also here. These are called typically bridging veins. So they're, I know it's represented a little bit simplistically in this diagram. This is more anatomically sort of truthful. So these are big collecting veins in the subarachnoid space adjacent to the arteries, the cerebral arteries. And then these little bridging veins empty into the sinuses for venous drainage. And that is typically the site of a tear that precipitates a subdural hematoma. So because subdural hematomas typically arise from venous bleeding, they look different on imaging, characteristically. So first, they're in a different compartment. You can't necessarily see that on imaging, but they're in the space between the dura and the arachnoid, so deeper in the meningeal sandwich outside the brain. As I've said, they're usually due to bridging vein rupture. And unlike the epidural hematoma, in which spread of the blood is constrained by the skull sutures, this blood moves relatively easily around the outside of the brain. And so instead of that sort of big fat lens, you get a long, narrow, crescent-shaped hematoma that seeps along the skull. There are two types. They can be chronic or acute, and they're distinguished by different appearances on CT based on their relative density. So this happens to be a left side chronic subdural hematoma, and I can tell because it's dark on CT. So it's lost some density. Now, chronic subdural hematoma is often seen in older or elderly patients. So the atrophy actually, your brain shrinks with age, and so that allows the brain to move more within the cranial vault, and so brain movement increases the vulnerability of bridging veins to shearing because the brain's moving more relative to the skull. And often, an epidural hematoma, people typically know what happened, right? Car crash, punched in the head. Subdural hematoma, it can be a much more subtle injury, so they may not report an injury, or it might be very minor. And in a chronic situation, this slowly oozing venous blood collects over a period of weeks to months, and that allows the brain and its function to accommodate, right? So there's much more accommodation with this slow oozing of venous blood that spreads than there is in an epidural hematoma, which arises from an arterial source and punches out into the brain. You'll notice that we didn't talk about an appearance of a chronic epidural hematoma, and typically that doesn't happen because there are neurological deficits and consequences far before the chronic stage. In contrast, you can have a chronic subdural hematoma, as we see here, with vague symptoms, maybe a little bit of a headache, if and when imaging is finally done, a chronic subdural hematoma will appear hypodense on CT. So this is how it changes over time from acute to chronic. If you do happen to image an acute subdural hematoma, it is hyperdense. And so it's got this thin crescent shape. Unlike the lens shape, it's spread, and it's clearly spread here from the temporal bone across the frontal bone. And so you can see that it's crossing skull sutures. And that makes sense because it's not adjacent to skull sutures. It's deep to the meningeal dura. Is that right? Yes, meningeal dura, subdural. Good. You can see the pronounced lateral mass effect here. The whole brain contents are shifted pretty dramatically toward the right, and the left lateral ventricle is compressed. There's a period as sort of this blood clot, which is what makes it hyperdense in the acute scenario. There's a period of isodensity. The blood clot is gradually liquefying, and that's what you can see here. You can't really reliably see where's brain tissue and where the bleed is. The bleed happens to be on this side in this case. And finally, you've got the chronic scenario. And so in this case, this is a right-sided chronic subdural hematoma, and the bleed ultimately is slightly, the hematoma is hypodense because the clot's been replaced by fluid. Now, I want you to notice the shape of this. So it looks like a banana, right? So that it's really important to see that this deep surface of it is concave rather than convex. And that's the clear difference, as well as crossing beyond the limits of several bones around the skull. Those are the differences between an epidural hematoma on imaging and a subdural hematoma. Now, this is an interesting scenario. So in this person, this is what's called a hematocrit effect. This is continuous bleeding in a subdural hematoma, and the person's lying in a bed, and they have a subdural hematoma on the right, and the bleeding is continuous such that the hyperdense new blood settles posteriorly in the back of the skull, at the posterior or caudal portion of the hematoma, while the hypodense fluid rises to the top. And so that's a sign that it is a subdural hematoma, but bleeding is ongoing. Now this is a funny one. This is a case of a gentleman who had a roller coaster induced subdural hematoma. He's an older gentleman, I believe. Yes, he's 64. And he rode the roller coaster 11 different times on 11 different occasions. So it wasn't 11 times in a row, but 11 times. And then he presented with a left-sided chronic subdural hematoma. You can see the mass effect here, compressing, shifting his brain toward the right, and compressing his left lateral ventricle. And this is him post-surgery. I believe he had surgery. Did he have surgery? Yes, surgical removal, good. You can see that he recovered, and so there's no hematoma persisting there. That space is an artifact, that is not hematoma. And what you can see, this is a slightly deeper plane, and so we're seeing in his posterior horns, and perhaps the third posterior horns of the lateral ventricles, and the third ventricle, those are normal ventricular calcifications with age. So those are hyperdense calcified choroid plexus. Okay. It's getting late. The dog's getting sad. Hey, Lindsay. She's in her doggy bed in the lab. So we better finish this off. So, right, I was on the slide. And this also talks about a subdural hematoma. So here in A and B, this is hematoma with compression. And in C and D, the same approximate axial levels you're looking at have been decompressed. And the hematoma has been evacuated. And so here we see an acute subdural hematoma. It's got all the characteristics. It spreads in a long, narrow crescent. In this case, almost the whole rostrocaudal extent of the left hemisphere of the brain. And what you see in this inferior section is, so you can see mass effect here. The brain is shifted rightward, compressing the left lateral ventricle. And what you see in this section is something we alluded to before, and that's that this, if you look at the brainstem, it kind of looks like a heart, like a hallmark heart. Gosh, I hate myself right now for referring to that. But you can see, let's call it a butterfly, or a moth, perhaps a moth, with the state of our times. And so here you can see that the brain's rightward displacement is also producing transtentorial compression. And the transtentorial compression or transtentorial herniation is squishing the right cerebral peduncle against the tentorial notch. And so this is actually producing left-sided weakness. Now I just want to review this anatomy a little bit. And so you know the internal capsule. So here we're looking at the internal capsule fibers that sweep and coalesce into the cerebral peduncle. And then they travel the length of the brainstem and they decussate down here at the level of the caudal medulla in the pyramidal decussation. So if we've got compression of this cerebral peduncle and the rostral midbrain on the right, we will have left-sided weakness or paralysis in our patient, because those fibers in the pyramidal tract haven't crossed the midline yet. Now this is the normal scenario, so you can see here the hematoma has been evacuated, the ventricles are symmetrical once again, and the mass effect has been alleviated. Everything's shifted back, and the cerebral peduncle on the right is restored to its full moth wing shape. And so probably the paralysis or weakness on the left side of the body would also resolve. Obviously, it depends how long it was compressed for. So a little more anatomy. Now we're looking again at the ventral side of this plastinated brain specimen, and the peduncles are right here. So those are the cerebral peduncles, those dense collections of white matter, the inferior continuations of the internal capsule. As they enter the brainstem, this is the midbrain. And you can see them again in a lateral schematic view. Here they are in a cut section, sort of en face is what we would call that section, a transverse section. And that's the lateral view, rostral to the pons. So this is summarizing some of the typical characteristics of epidural versus subdural hematomas. So the epidural hematoma is typically arterial blood. It could be secondary to a skull fracture. And this is sort of the typical case where the middle meningeal artery has been affected by a lateral skull fracture and filling this epidural potential space with blood. The blood does not cross the suture line of the bones of the skull, and so it punches out into this convex shape into the brain parenchyma, or the center of the brain. Conversely, the subdural hematoma is deeper. It's constrained between the meningeal dura and the subarachnoid space, and the arachnoid, say that again, sandwiched between the dura and the arachnoid in the subdural potential space. It's typically venous blood, often derived from a bridging vein, and it will spread quite happily beyond the limits of the skull suture. It produces a narrower, more crescent shape hematoma. Now, we haven't talked yet about the venous sinuses, so we want to review the major venous sinuses. So the false cerebri contains 3 of them. So the first is the superior sagittal sinus, adjacent to the skull. The second is the inferior sagittal sinus, which is on the inferior free edge of the false cerebri. And the third, I've already mentioned, is the straight sinus, and that's where between the junction of the false cerebri and the tentorium cerebelli. And many of the veins on the surface of the cerebral hemispheres empty into the superior sagittal sinus. So this is a really large site of venous drainage. Now, deep to that, moving into the base of the skull, we've talked about the straight sinus at the junction of these 2 dural folds. The tentorium cerebelli similarly contains multiple sinuses. So there's transverse sinus, which is posterior, which is at the junction puts a groove at the junction of the tentorium cerebelli with the occipital bone of the skull. The sigmoid sinus, which is the inframedial continuation of the transverse sinus, which ultimately exits the tentorium and drains into the jugular vein bilaterally. And there's one more I think I mentioned on the slide. Oh yes, the superior petrosal sinus. And that is actually at the rostrolateral junction to the petrous portion of the temporal bone. So it goes transverse sinus, sigmoid sinus, and superior petrosal sinus. Oh, I see the problem. Okay, I'm going to start over. It is over here. You can see these better. So the superior petrosal sinus is here, immediately adjacent to the sigmoid sinus. And so on this slide, you kind of see them merged together. And on this slide, you can see them separated out. So now I know in 326, we kind of just learned confluence of sinuses. It's actually generally not symmetrical. So most of the blood from the superior sagittal sinus flows to the right, whereas blood from the straight sinus flows left. And so as a result, the right is often bigger. So the right transverse sinus is slightly large compared to the left transverse sinus. And you can kind of see the path of both of them here. And this is a good view, actually, of the superior petrosal sinus. So this is the confluence of sinuses. You can see the transverse sinus, this groove pass around, and the sigmoid sinus, which descends toward the internal jugular, or drains into the internal jugular, and the superior petrosal sinus runs as a branch point of the sigmoid sinus. And I'm mentioning that because it connects to some anterior plexes, yes, which I think are here. And so you'll see that the plexes in the base of the skull are actually huge. Some of the sinuses are big, complex aggregates of veins. We're not going to go into the specifics of those. Here's another view, because I feel like I did a bad job, of sigmoid sinus draining almost parallel to superior petrosal. Now, the sort of final kind of hemorrhage occurs in a physiological space. So the subarachnoid hemorrhage occurs in the subarachnoid space, and this is the CSF filled space between arachnoid and pia. So it contains the major cerebral arteries, and unfortunately, this can be traumatic or non-traumatic. Now, unlike an extradural hematoma or a subdural hematoma, the blood is not contained here. So it's in a normal physiological space, and this is what it looks like on imaging, acutely, because it is absolutely flowing over all of the sulci and the gyri. And because the blood flow is not limited, 25% of patients die immediately, or there's no time to treat, and the overall mortality of a subarachnoid hemorrhage is about 50%. So it can be diagnosed acutely on CT because you have these hyperdense patches of blood all over the brain. And it can be diagnosed more chronically if it's a slower hemorrhage using a sample of CSF. And how do you sample CSF? Clinically, the most common route is a lumbar puncture. And so this is a needle inserted into the subarachnoid space. Now, if you remember your 326, you remember that the spinal cord ends between the L1 and L2 vertebral bodies. So the spine is longer than the spinal cord. And so you harvest CSF in a lumbar puncture by inserting a large needle into the subarachnoid space below the level of the spinal cord, because you do not want to put a needle into the cord. So a normal sort of location is between the L4 and L5 dorsal spinous processes in an adult. You can use this test, so you can see here it has a manometer on it, so you can get an idea of intracranial pressure, or this is called opening pressure, but because it's continuous with the subarachnoid space of the brain, it is related to intracranial pressure. More commonly, it's used to test for stuff in the CSF. And it could be, in this case, blood. If you were diagnosing a potential subarachnoid bleed, there would be blood in the CSF. You could look for white blood cells to test for the presence of an infection like meningitis. And you could look for cancer cells to look for metastatic cancer that's spreading via the CSF. Now, the most common cause of a spontaneous subarachnoid hemorrhage, so without trauma, is the rupture of an aneurysm. And aneurysms are just outcroppings or outpouchings of a vessel that create a spot of fragility. And so saccular or berry aneurysms typically arise at branch points, and often they're near the circle of Willis. So the most common locations are the anterior communicating artery. You can see there's a little bubble on it. That is an aneurysm. A posterior communicating artery, where is he? There he is, right there. And less commonly, the middle cerebral artery. And of course, they can occur anywhere. Here they're showing one on the pica. But these are the most common locations of a saccular aneurysm. And so saccular aneurysms create a vulnerability to rupture. You can also see other types of aneurysms. So an aneurysm is just an outcropping of a vessel, and in this case, you're looking at an enlargement of the whole basilar artery, and that's called a fusiform aneurysm. So those are also vulnerable, but my impression is that these saccular aneurysms, particularly of a small artery, are most vulnerable to rupture. Now, an important consequence of the brain, of a clinical consequence of the meningeal innervation pattern, I'll back up, I'm starting this slide badly. Unlike the other meninges, and unlike the cortex itself, the dura has sensory innervation. So the dura is pain sensitive. So we all know that you can have brain surgery. We've seen those videos. Do you smell burnt toast when you stimulate different parts of the brain? And so we know that you can do brain surgery in an awake patient. But to do that, in addition to anesthetizing the skin and the scalp, you have to anesthetize the dura because the dura is innervated. So the false cerebri and the anterior middle cranial dura are largely innervated by the trigeminal nerve. More posterior in the cranial fossa, the dura is innervated by the glossopharyngeal and vagus nerves. And this dural innervation is what causes the pain when you have meningitis, an inflammation or infection of the meninges. So I've known people who've had, in this case, a bacterial meningitis, is the case I can think of off the top of my head. Anyway. So he had a bacterial meningitis, and he described it as the worst headache of his life. and that's what brought him to hospital, mercifully, because he was seriously, seriously ill. And so this, in this case, and this is an autopsy after pneumococcal meningitis, and you can see the pus gathering all over his brain, deep to the dura. So the dura has been reflected, and deep to that is purulent inflammation. And so the inflammation of the leptomeninges is actually, the pain is detected by innervation of the dura.